my name's Dr. Andy Lee, and I'm the neuro-ophthalmologist here at Houston Methodist Hospital. And today we're going to be talking about retinal migraine. And many of you are already familiar with migraine headache, which is throbbing, pulsatile, associated with nausea, vomiting, sonophobia, photophobia, disrupts activities of daily living, and the patient has to go lie down in a dark room. That's your typical migraine patient. And some of those migraine patients can see an aura, and the aura is usually a jagged line, which we call a fortification scotoma, and it's sometimes associated with a flashing colored light, which we call a scintillating scotoma. So they see colors or a kaleidoscope. And normally with the migraine aura, it's associated with march and buildup, which means that it starts small and then it gets bigger and bigger over time. It lasts 20 minutes and then the headache follows, the typical migraine headache. Retinal migraine is a little bit different because what it means is it's only one eye. So they draw out, or they say, look, I covered one eye, and it's just one eye only causing it. And so it can be a half of a field like this, or it can be they saw the flashing light, but they're very clear on it being monocular, and that's the retinal migraine. The reason it's dangerous to make the diagnosis of retinal migraine is it's a diagnosis of exclusion. So the typical retinal migraine has to be completely monocular. It has to come on, last minutes at a time, and then go away with no residual, and the typical migraine has to follow. And because so few patients actually meet all of those criteria, you probably really should be working up retinal migraine if it's no headache, which we call the acephalgic form. You should also be doing the visual field on this patient. And so when we do a visual field, it has to be completely normal. So here's the field. So if the patient has a homonymous hemianopsia or a bitemporal hemianopsia or any field defect, especially respecting the vertical meridian, that is not retinal migraine anymore. That's an intracranial lesion that needs to have an MRI. And if it's retinal migraine with no headache, we could still have that, but we call that retinal vasospasm instead of retinal migraine now, because it's not probably truly a migraine anymore. So retinal vasospasm means the blood vessel constricts. It takes the vision. It can be altitudinal, half, or it can be the whole visual field. It can be mild, moderate, or severe. And it's thought to be vasospasm at the level of the retina. Photographs have been taken during events of retinal vasospasm that can show the vasospasm. Again, you have to do a visual field. There can't be any permanent residual field defect. You have to look in the fundus and make sure there's no blood clot. And probably, if they're in the vasculopathic age range, we do need to work up retinal vasospasm for TIA, the transient ischemic attack, amaurosis fugax, the transient fleeting blindness, and that means echocardiogram, EKG, cardiac monitoring, checking their blood counts, and doing an MRI. So for retinal vasospasm in young patients or older patients, probably you should consider working it up for TIA. If the workup is negative, then you can call it retinal vasospasm by exclusion. If, however, you have the typical migraine headache that follows, even if it's completely monocular, that is the diagnostic criteria for retinal migraine. And that one also is probably a diagnosis of exclusion. So you need to know that the migraine can cause visual loss in one eye only, and we call that retinal migraine.